This content is AI generated for informational purposes only and should not be directly used for clinical decision-making.
Hello and welcome back to the Neurosurgery Hub podcast. I'm Dr. Aris, Senior Attending Neurosurgeon.
And I'm Dr. Alara. Today we're looking at a fascinating new study from Epilepsia Open, published in 2026. It's titled, Scalp Fast Oscillations Detected by High-Density EEG as a Non-Invasive Predictor of Surgical Outcome in Temporal Lobe Epilepsy with Hippocampal Sclerosis.
This is a topic that sits right at the intersection of functional neurosurgery and advanced neurophysiology. We're talking specifically about patients with drug-resistant temporal lobe epilepsy, or TLE, where we see confirmed hippocampal sclerosis, or HS.
Right. And for these patients, the gold standard treatment is often an anterior temporal lobectomy, or ATL. But as we know in the clinic, while ATL is highly effective, not every patient achieves that coveted angle class 1 seizure-free outcome. The challenge has always been, how do we predict who will benefit most before we ever pick up a scalpel?
Exactly. Historically, we've relied on semiology, MRI, and standard 10/20 scalp EEG. If those aren't concordant, we move to invasive monitoring with intracranial EEG to find high-frequency oscillations, or HFOs, which are excellent biomarkers for the epileptogenic zone. But this paper explores a way to stay non-invasive for longer.
That's the core of the study. They evaluated whether scalp oscillatory patterns, specifically what they call scalp fast oscillations, or SFOs, could serve as that predictor. These are oscillations in the frequency range above 30 Hz.
Now, for the residents listening, detecting 30 Hz and above on the scalp is notoriously difficult because of muscle artifact and the low-pass filtering effect of the skull. How did this group overcome that signal-to-noise ratio problem?
They used 256-channel high-density EEG, or HDEEG. By using such a high density of electrodes, they can achieve much better spatial resolution and use advanced signal processing to isolate these SFOs from the background noise. The study specifically wanted to see if these scalp-fast oscillations were associated with and can predict surgical outcomes following an ATL.
This is a shift in the paradigm. We've known about HFOs on invasive recordings for years, but the idea that we can detect scalp-fast oscillations non-invasively to predict an ATL outcome is a potential game-changer for our pre-surgical workup.
It really is. The study focused on drug-resistant TLE-HS patients. By looking at the presence and distribution of these SFOs, they were able to correlate the preoperative EEG findings with the postoperative results.
Let's dive deeper into why the fast part of scalp-fast oscillations matters. In the abstract, they define these as being greater than 30 Hz. Why is that specific threshold important for a neurosurgeon planning a resection?
Because frequencies above 30 Hz, moving into the gamma range and beyond, are thought to be more closely linked to the actual site of seizure generation. If these SFOs are localized strictly to the area we plan to resect in an anterior temporal lobectomy, the likelihood of surgical success goes up. The paper suggests that these oscillations are a non-invasive predictor of surgical outcome.
So if I'm sitting in a multidisciplinary epilepsy board meeting and we have a patient with TLE-HS, I'm looking at the MRI showing the sclerosis, but maybe the standard EEG is a bit lateralized but not perfectly localized. If we run a 256-channel HDEEG and find these SFOs concentrated over the temporal pole, does this study give us more confidence in the ATL?
Precisely. It provides a biological marker that confirms the sick tissue is where we think it is. The study highlights that the ability to detect these SFOs non-invasively could potentially reduce the need for some patients to undergo invasive electrode placement, which obviously carries risks like hemorrhage or infection.
It also helps us manage expectations. If a patient with TLE-HS lacks these scalp-fast oscillations, or if they are found extratemporally, we might have to be more cautious about promising a seizure-free outcome with a standard ATL.
Exactly. It's about precision. The study concludes that these oscillations are indeed a non-invasive predictor. For the medical students listening, it's a reminder that neurosurgery is becoming just as much about high-level electrophysiology as it is about technical skill in the OR.
Well said, Alara. This study from Epilepsia Open 2026 really pushes the boundaries of how we use HDEEG in clinical practice. It turns a standard diagnostic tool into a powerful predictive instrument for TLE-HS.
It's a great step toward more personalized, data-driven surgical planning.
That's all the time we have for today. Thank you for joining us on the Neurosurgery Hub podcast. I'm Dr. Aris.
And I'm Dr. Alara. We'll see you in the next episode.